Hi everyone, Dr. Mike here. In this video, we're taking a look at how oral contraceptives work. So to begin, we need to understand that the whole purpose of oral contraceptives is to stop pregnancy from occurring. And there's two major types of what we call the pill. The first is what we call a combined pill. So there is a combined pill, and this combined pill contains both progesterone and estrogen. Now, what is progesterone and estrogen? So, firstly, progesterone is the umbrella term used for synthetic progesterone. So remember, in the body, we produce progesterone, but we don't use this endogenous hormone, the one that we produce. We use a synthetic version in the pill, and that's called progestin or progestins. Estrogen, again, is the umbrella term used for the estrogens used in the pill, and the major estrogen that plays a role in the female reproductive cycle is estradiol. So the combined pill has both estrogens and progesterone, or estrogen and progesterone. The other pill type is progestin only. So it's just, for sake of simplicity, progesterone. Progestin only. So let's park that. We know there's two major pill types now. To understand how they work, we need to understand the physiology of all these steps that need to occur in the right order for pregnancy to occur, right? So number one, we have the ovary. And you can see that next to the ovary, we've got the fimbriae, the fingertip-like projections of the uterine tube, which connect to the uterus, cervix, vagina. All right, so we've got our anatomy down pat. What happens, first thing that needs to happen in order for pregnancy to occur is that inside the ovary, we have a whole bunch of oocytes or eggs. And these eggs are nourished by a collection of cells that surround them called a follicle. They're follicle cells. And there's different types. There's granulosa cells and theca cells. I'll get back to that in a sec. So we've got what we call a follicle, also known as a primordial follicle. It's a very early stage follicle. And what this follicle needs to do is it needs to mature and develop. So effectively, this follicle needs to mature and develop into, unsurprisingly, something that we call a mature follicle. Now, a mature follicle still has the egg or oocyte inside, but those follicle cells, the granulosa and theca cells surrounding it, become very, very abundant, right? And again, just continues to nourish that oocyte inside. Now, this first step we call follicle development. That must occur. All right, so now we've got a follicle that is developed, a mature follicle. The second thing that needs to occur is that this follicle needs to ovulate and release the egg. So this follicle needs to ovulate and release the egg, and it sort of outpouches from the ovary itself, and it releases the oocyte or egg into the uterine tube. And we're left with this body. This body is called the corpus luteum. I'll write that down. Corpus luteum. All right. So the second thing that needs to happen here is ovulation. Ovulation. All right. Now, the third thing that needs to happen is that we've got the oocyte inside the uterine tube. It needs to become fertilized. How does fertilization occur? Well, fertilization occurs because we have sperm that will get deposited into the vagina. It needs to traverse through the vagina, through the cervix, through the uterus, into the uterine tube, where it generally at the ampulla will fertilize the oocyte. So you have the oocyte, and you have the sperm, and you have the third thing that needs to happen, which is fertilization, but sperm needs to transport for fertilization to occur. So let's write down here, the third thing that needs to happen is sperm transport, ultimately resulting in fertilization. All right, so we've got our third thing. What's the fourth thing that needs to happen? This is the last one. Fourth thing that needs to happen is the fertilized oocyte needs to implant in the uterine wall. And in order for that to happen, the uterine wall, specifically the functional layer of the endometrium. It needs to thicken. It needs to become more vascular. It needs to become more glandular to secrete a whole bunch of important chemicals. And now we can have a developing or fertilized oocyte implant into that wall. So the fourth thing that needs to happen is we need endometrial lining development. And the whole point of that is for implantation. Implantation. Great. All right. These are the four things that must happen in order for pregnancy to occur. Now, we need to talk about the hormones that regulate it, because as we know, if you have watched my video or videos on the female reproductive cycles, the ovarian cycle and the uterine cycle, there's a whole bunch of hormones that regulate them. So we need to talk about those. So let's start here for follicle development. At the beginning of every reproductive month, 10 to 30 of these early stage, what we call primordial follicles, will develop and begin to mature. Now, this happens, think about this, and this is a crazy fact, when a female is developing inside their mother's womb, so they are, let's say 20 weeks gestation, right? They're only 20 weeks old in their mother's womb. They, inside of their ovaries, will have 7 million of these primordial follicles. By the time they are born, right, which is not that many months later, they only have 1 million of these primordial follicles. And then by the time they hit puberty, they've only got 300,000 of these primordial follicles. That's interesting. And the reason why is because, like I said, at the beginning of every reproductive month, 10 to 30 of these follicles will develop and then die until puberty. Because when puberty hits, the body releases something called follicle stimulating hormone, FSH. And follicle stimulating hormone, its job is to deselect the largest, generally, of these developing follicles to mature, to ultimately ovulate. Right, so FSH needs to be released in order for the follicle to reach the end stage of development. FSH. Great. Now the thing is, when FSH allows for this to happen, now we've got a mature follicle. This mature follicle, the granulosa and theca cells, they pump out a whole bunch of estrogen. A whole bunch of estrogen. And what does estrogen do? Estrogen can help develop the endometrial lining in the early stages. Estrogen is really important to develop that endometrial lining. Okay. FSH ultimately produces estrogen, and estrogen will help develop the endometrial lining. Next step is ovulation. Now again, once puberty hits, there is another hormone that's released from the brain in addition to FSH, and that's called LH, luteinizing hormone. What luteinizing hormone allows is ovulation. Luteinizing hormone allows for ovulation to occur. And once ovulation has occurred, this corpus luteum, this body here, produces a huge amount of progesterone. All right, so that means that luteinizing hormone helps produce progesterone. And what does progesterone do? Progesterone helps further develop and mature the endometrial lining. Okay, very good. We've got this sorted. Now, a couple of things. Considering that FSH ultimately allows for estrogen to be produced, it makes sense that estrogen can have a strong negative regulatory effect on FSH. That's just called feedback. That's homeostasis. Because if that goes unchecked, you just have more FSH, more estrogen, more FSH, more estrogen. But the more FSH that you produce, the more estrogen you produce, and then that negative feedback occurs so that it maintains relative levels, which also means, unsurprisingly, that progesterone has a strong negative effect on luteinizing hormone as well. And this we need to understand in order to understand these pills. If we were to graph up what's happening across the general 28-day reproductive cycle, so let's say here is day 14, here is day 0, and here is day 28. What's generally happening? So let's take a look at FSH and LH, and let's have a look at them. So I'm going to do LH in this color. So we've got, let's do FSH first. So FSH is going to be in this color. What we find, because this is the beginning of the reproductive cycle, right? The FSH is going to be up here. And what we also find is that LH, luteinizing hormone, is also relatively high as well, but not as high. All right, what did I say? FSH ultimately allows for estrogen to be produced. So let's now draw up estrogen. So we've got estrogen here, and estrogen is going to start low, but because of the FSH, the estrogen levels go up. Now, interestingly, as the estrogen levels go up, you get negative feedback. All right, that makes sense, right? We get negative feedback. So what happens to the FSH is they start to drop off, right? And estrogen also will have a slight negative feedback on LH. That's because they're released from the same area of the brain, right? So we can also say, yeah, LH does drop off a little bit as well. Then something weird happens. For whatever reason, when estrogen levels get really high, they no longer have a negative effect on FSH and LH. It has a positive effect. It positively feeds back. So then, just before day 14, so let's draw this up. I've got a handful of markers here, so I'm probably going to drop one at some point. As the estrogen levels, see, go up, it then no longer has a negative feedback effect. It has a positive, and you get a spike in FSH and a big spike in LH. All right, you get a big spike in LH. And what does this big spike in LH do? It stimulates ovulation, which is occurring at day 14, right? It is occurring at day 14. That makes sense. LH stimulates that. But then we've got this corpus luteum body that's produced, which is producing progesterone. So let's do progesterone. Let's do it in green. Hopefully you can see green. It's not a very good color to draw on a whiteboard, but hopefully you can see it. Progesterone, it's low until after day 14, and then it boosts up and remains high for about 10 days and then drops back down. And so let's just finish up what we've drawn. The LH spike happens and ovulation occurs and it can drop back down. The LH spike has occurred, but also drops back down with LH. With FSH. The FSH spike occurs and drops back down with LH. And then the estrogen spike, because it's done its job, it starts to drop back down as well. You actually get a little spike here, but here we go. All right. So hopefully this is starting to make a little bit more sense now. What do you see? A couple of really important points is that this first phase here, this is called the follicular phase. Follicular phase. Why do you think it's called the follicular phase? Because that's when the follicle is developing. That's the first 14 days. The next phase is called the luteal phase. And that's unsurprising because that's when the corpus luteum is controlling the release of progesterone. All right. Now you're probably thinking, explain how these oral contraceptives work. All right. If we're going to now give somebody, let's first start with progestin only. We give someone an oral contraceptive pill and it's progestin only. What you can see on a normal 0 to 28 day reproductive cycle is there's a whole bunch of peaks and troughs of hormones. This is across a month. But if you were to zoom in and look at it, every 90 minutes, FSH and LH actually peak and trough. And the other hormones also have cyclic peaks and troughs throughout the day. So generally speaking, not only do you get peaks and troughs throughout the day, or hours, you get it across the months as well. This is so important. It's the peaks and troughs of hormones that stimulate the changes in the body. It's the peaks and troughs that stimulate the changes. So when somebody takes a progestin-only pill, and I said progesterone here is in green, so let's just say they take a progestin-only pill, this pill is going to be higher than its lowest level, right? But it's going to be lower than its highest level. So we've got progestin only, right? So there's progestin. It's like that, quite steady across that time period. Now, what does this mean? All right, firstly, I said that progesterone strongly negatively regulates LH. And LH is important for ovulation. So the first thing you need to understand is that one of the important roles of progesterone only is that it inhibits ovulation. And that makes sense because it's the negative feedback on luteinizing hormone. All right, that's the first thing. So ovulation doesn't occur. Next thing you need to understand is this, the endometrial lining. I said that we need progesterone in order for this endometrial lining to develop, right? And you're probably thinking, okay, well, I've got relatively high levels of progesterone on the pill, so this endometrial lining should develop. And that's true, but here's the important thing. Progesterone is low in this follicular phase, and it's estrogen in this follicular phase that rises up that helps stimulate the endometrial lining to develop. And so this is important. So if you've got what progesterone does in the latter stages for endometrial lining development is it helps mature the endometrial lining. It implants, it allows for it to become more vascular and glandular. But if you make it too high too early, it's trying to mature an endometrial lining that isn't developed or stable yet. And so what ends up happening is it can atrophy and thin. And so what this progesterone does, particularly in the follicular phase, is it doesn't promote the endometrial lining to become nice and thick. It actually stimulates it to atrophy and become thin. So you get thin, atrophied endometrium. Thin, atrophied endometrium. What does that mean? That means it's not good for implantation. So that means it helps stop implantation. All right. Next thing that we need to understand is sperm transport, right? The sperm needs to get in, it's deposited into the vagina, needs to get through the cervix and swim to the oocyte. What progesterone does is it produces mucus. And so if you've got progesterone produced throughout this whole phase, you've just got a whole bunch of thick, viscous mucus that's produced here in the cervix, and this inhibits the sperm from being able to travel through. So the next thing that progesterone will do in the pill is it creates a thick cervical or cervical mucus. And this stops sperm transport. Okay, look at that. So progesterone can affect predominantly 3 of these things: ovulation, endometrial lining development and implantation, and sperm transport, and ultimately fertilization and implantation as well. So that's the progesterone. What about estrogen as well? Well, let's have a think. I said estrogen negatively feedbacks FSH, but what else did I say? I said at relatively low levels, estrogen has negative feedback. But then I said at higher levels, estrogen has a positive feedback. So your thought might be, okay, where's estrogen sitting on this graph? Well, the estrogen levels will be sitting, where do you reckon? At around about the lower levels, right? Which means the estrogen that's in the pill sitting at these lower levels has a negative feedback on FSH. So the estrogen, negative feedback on FSH. And what do you think that means? That means that there is going to be no follicle development. No follicle development. Now, I also said that estrogen is important for endometrial lining development, which it is. And you might think again, well, we've got relatively high levels of estrogen on the pill, therefore it's going to help develop it. No, remember, it is the slow gradual rise in estrogen that allows for the slow gradual development and stabilization of the endometrial lining. So, again, estrogen will not allow for a stabilized endometrium. doesn't allow for a stabilized endometrium. And this is important when it comes to something called spotting or bleed breakthrough, right? Because when some people are on the progesterone only pill, right, what you can get is a bleed breakthrough, meaning they sometimes bleed or spot during being on the pill. And the reason why is because estrogen, what's its job? Is to stabilize the endometrium. Because as the estrogen levels go up in the follicular phase, it allows for the slow development, stabilizes that endometrium as it gets bigger. Then as progesterone goes up in the luteal phase, it matures the endometrium. But if you're on a progesterone only pill and you're trying to mature something that's not stable, well, you can get some of that tissue falling away. And while it's not a full period, it might be a little bit of tissue that's coming out and it leads to a bleeding, a small bleed or spotting or bleed breakthrough. So that's really important. Now, another point I'd like to highlight here is that why would you only have a progesterone only pill? Why wouldn't everyone just take the combined pill if it has a better efficacy, able to stabilize the endometrial lining? And the answer is because there are some effects for some people for taking estrogen. And so, for example, estrogen can be contraindicated in some people who are at risk of clot. So there's a clot risk. So some people who might be at risk for things like DVT or stroke may not take the pill with estrogen. Some people who have uncontrolled hypertension, right, may not take the pill either. And there's also a whole range of other contraindications in which people may not take the combined pill. So I'm hoping that this physiological understanding of oral contraceptives help. And I'm Dr. Mike. Leave a comment, subscribe. Thank you so much. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMiketodorovic. Speak to you soon.